Bonjour, bon dia, good morning everyone. My name is Nyaradzo from the University of Zimbabwe. I have no conflict of interest to declare. So practically the whole of yesterday we heard about how HIV is still a burden here in sub-Saharan Africa. The PEPFAR ambassador, Dr. John Gekasong, Dr. Francisco Mbofana, Jabulani Mavudze, Gloria Bile, almost everyone yesterday spoke about how HIV is still a problem. So despite the major advances in HIV prevention and treatment, the global burden of HIV remains unacceptably high, especially here in sub-Saharan Africa. So we know that a single product will not stop the pandemic. A single approach will not stop the pandemic. We know that, and we'll hear from my good friend here, Nono. She'll talk about progress towards an HIV vaccine. We know that in the long term, we need a safe and efficacious vaccine, and we know that the availability of an HIV vaccine will be essential to a world without HIV. And we'll also hear about cure. So we know, I'm trying to reiterate that a single product, a single approach will stop the pandemic. We need this entire toolkit of HIV prevention measures. So in the meantime, which short-term or medium-term approaches are we looking at? I'm not sure if Nono will talk about broadly neutralizing antibodies, but they are also in use. There is ART-based, antiretroviral therapy-based, and non-retroviral-based interventions. There's structural and behavioral interventions, and these are administered on an on-demand, long-term or short-acting prevention against HIV. So this is the HIV prevention toolkit that we have, and we need to continue adding onto it if we are going to beat this epidemic. The great Maya Angelou said, you cannot really know where you are going until you know where you're coming from. So we need to know where we're coming from in terms of HIV prevention. We know that oral PrEP is highly efficacious. However, a decade after its approval, only a fraction of people who need oral PrEP are using it. To date, about 3.9 million people have initiated PrEP. Though this might look impressive, it only represents about 10% of people who need it. Also, the distribution of PrEP and the uptake of PrEP is not equitable when compared to the distribution of new HIV infections. We know that there's regional disparities, sub-Saharan Africa, Asia Pacific, Latin America. So there are barriers to oral uptake and oral PrEP uptake, and I'm sure they will be discussed further in some sessions during this meeting. So we really need to address the structural, individual, interpersonal barriers that people experience during PrEP use. Here I'm just sharing, and thanks to my Minister of Health and Childcare, here I'm sharing the HIV prevention programs roadmap in my country, in Zimbabwe. What I would like you to pay particular attention is that Zimbabwe, we only started rolling out oral PrEP in 2018. So there was a gap in terms of its approval and the time we got to roll it out as a country. And as we progress to the right of the diagram here, I'm seeing that it's shorter and shorter. We are going to start implementing CAB-LA and the dapivirine ring soon. So the time from proof of concept, approval, registration to roll out is getting shorter and shorter. And that's what we should aim for when we look at new HIV prevention technologies. So we need to know where we came from. As we prepare for new HIV prevention technologies, we need to take the lessons that we learned from before and start preempting any problems that we faced so that they the rollout of new prevention products becomes seamless. We need to, and thanks to Linda Gale Becker for sharing some of this information with me, we need to introduce future HIV prevention options via channels and approaches which are preferred by potential users. I'm an African woman. I know what I need. My lifestyle is busy. I'm the one who knows what I need in terms of HIV prevention. So we need to engage the potential end user, the stakeholders, and we need to invest and expand in demand generation. We use service delivery models that help users to access PrEP. And of course, there should be evidence-based decision making. We also learned, so I'm still talking about the past. We also learned that users have certain preferences for antiretroviral therapy as well as pre-exposure prophylaxis. You can see at the bottom of the slide that there are many biomedical interventions, the ring, oral PrEP, implants, and both people who are living with HIV and those who need HIV prevention, they've stated that some need long-acting interventions, some need systemic interventions, some need topical. So we really need to take cognizance of the preferences for ART and PrEP. So the youngsters here, Noah Beyonce, she's saying, lovely, lovely song. If you like it, single ladies, but it's not just single ladies, any lady. If you like it, if you like your vagina, then put a ring in it. Yes? So if you like it, put a ring in it, on it, in it. So this brings me to the monthly dapivirine vaginal ring. It was discussed yesterday. This is a flexible silicone vaginal ring which slowly releases the NNRTI antiretroviral drug dapivirine. It is modeled on the silicone ring delivery, which has been in use for quite a while, and it's safe, it's acceptable, and it has been used for hormonal contraception, and there's extensive safety data. So the dapivirine ring is the first ever woman-initiated product that is efficacious, modest levels of efficacy, self-initiated, and it is inserted monthly for 28 up to 35 days. It has no interruption with menses. It does not interrupt sexual intercourse. And it has been approved, as we all know, by several sub-Saharan African countries. And I would like to call out to Zimbabwe for being the very first country to approve the ring in sub-Saharan Africa. So even if it's less efficacious, my take-home message today is even if the ring, and yesterday I think you heard me talk about this, even if the ring is less efficacious than oral or injectable PrEP, it may be an essential risk reduction tool for women who are either unable or unwilling to take oral PrEP or injectable PrEP. So I'm still a fan of the box office, and I declare that I have no shares in Marvel Studios. So even our heroes, our Shiros in the mythical country of Wakanda, they do know that we as African women, we face many challenges in terms of our protection, whether protecting our families or whether looking after our sexual reproductive health. And they do know that we here as scientists have worked on the dapivirine ring. So you can see that even in the movies, they know that the dapivirine ring is an essential part of HIV prevention strategies. And they do know, these heroes, they do know that us as women, we face major challenges in terms of there's an unmet need for HIV prevention, for STI prevention, for pregnancy prevention. The contraceptive uptake in many of sub-Saharan African regions, countries, is not as good as it should be. So we, as African women, we need an intervention which will protect us from pregnancy, from HIV, and other sexually transmitted infections. Here, I want us to talk about the tenofovir levonorgestrel vaginal ring. This is a multi-purpose prevention technology which is designed to provide HIV, HSV2, and pregnancy prevention. It can be used continuously or for 90 days or on a cyclic basis every 28 days. And this is the most advanced multi-purpose technology intravaginal ring in the field. So like I've said, it protects against HIV, HSV, and pregnancy. And even if it's removed, it is pharmacologically forgiving when removed for 3 days. So this promotes increased adherence, and it does not, in the studies that have been conducted to date, it does not change the vaginal microenvironment. So women and us, the scientists looking at the vaginal microenvironment, we are very concerned about products that might affect the vaginal microenvironment, predisposing women to acquiring HIV. So the tenofovir levonorgestrel vaginal ring, safe, acceptable, does not affect the vaginal microenvironment, and it has minimal disturbances on the menstrual cycle. So there's been quite a lot of work which has been published, especially by colleagues at EVMS, and I would like to call out to Annie Thurman and Gustavo for this slide. So next is another multi-purpose prevention technology. So I've talked about what women want, what end users want. I talked about 5 slides ago, I talked about some people want orals, some people want injectables, some people want implants, some people want topical, long-acting, short-acting, on-demand, event-driven. So here it brings my discussion to another multi-purpose prevention technology, the dual prevention pill. In my country, in Zimbabwe, we know that women are more scared, especially the young women. They are more scared of getting HIV, of becoming pregnant than getting HIV. Yes, so young women in Zimbabwe are more anxious about pregnancy compared to HIV. So we need to take this knowledge into account. What can we piggyback on that women are doing so very well that we can provide protection, multi-purpose protection? So in terms of contraception, there is a multi-purpose dual prevention pill. This is currently being developed by public and private initiatives for daily use to prevent both HIV and pregnancy. It is one of the several multi-purpose prevention technologies. This is a single product that can be used to address multiple health needs, and it is in the pipeline. Currently, there are 2 DPPs, one which contains TDF, FTC, based oral PrEP with oral contraceptive, and then another DPP which is combining FTAF with oral contraceptive. It is also in development. So while we wait for this co-formulated dual protection pill, we are also currently working on an over-encapsulated dual prevention pill where, and this is being done under the auspices of Pope Council, where Truvada and oral contraceptives have been over-encapsulated into a single capsule. And we want to assess, and this study is being done in Zimbabwe and in South Africa in young women 16 to 30, and we want to see the continuation, the acceptability, the uptake of the over-encapsulated DPP. Let's come to injectables for HIV prevention. I think this is a very topical issue. We know that WHO has recommended the use of long-acting injectable cabotegravir to be offered as an additional prevention choice for people at substantial risk of HIV infection, but this must be part of a combination prevention approach. And we know that this approval came from data that was the demonstrations from HPTN 083 and HPTN 084, which showed that CAB-LA is highly effective and safe in two distinct populations who acquire HIV through anal sex and vaginal heterosexual vaginal intercourse. There was high adherence to CAB, and it is compatible with gender-affirming hormones. So with that recommendation, several countries have registered CAB-LA for use. And really, long-acting injectable HIV formulations will be a game changer for both treatment and prevention. However, there are some gaps that we need to fill, and this is where some of the technologies come in. There is need for information on people who inject drugs, sex workers, pregnant and breastfeeding persons, gender diverse populations. So there is an urgent need to continue looking or assessing other modalities that work for HIV prevention. One drug, an injectable, is lenacapavir, it acts as a capsid inhibitor, and it inhibits or disrupts multiple stages in HIV cycle. So it has the potential to work against HIV strains that have developed resistance to multiple other drugs, other classes. And it is being assessed as a subcutaneous injectable formulation with a long half-life, and is being assessed as a 6-monthly injection, twice yearly injectable PrEP. And it is being assessed in the two studies, PURPOSE 1 and PURPOSE 2. What about implants? Another drug, a good drug, is islatravir. This is a first-in-class nucleoside reverse transcriptase translocation inhibitor. It has got multiple mechanisms of action, so it's highly effective. Rates of resistance are going to be low, so it's got a high barrier to resistance, highly potent, small dose used, less risks in terms of side effects. So there's a slow release yearly implant, which is based on the Implanon. I'm sure we all know what Implanon is, Nexplanon technology, and this could broaden access to PrEP. And I really think that this implant could be transformative PrEP product. There are subdermal pellet systems. This is being worked on by Conrad. It targets a 6 to 12 monthly delivery of cabotegravir as a subdermal just beneath the skin. It is inserted as pellets. It is biodegradable, so there's no need to remove it. Of course, there will be pros and cons to a non-removable pellet system, but this is similar to how we inject depot injections. It has got flexible dosing, and it is suitable for busy, limited, resource-limited settings like my clinics, and I'm sure at CISPOC, I'm sure in Blantyre. This is something that we could deliver. And the manufacture and scalability is very similar like coated pills, so the cost is going to be lower. There are the next generation implantable drug delivery systems. As you can see here, there are many of them. Oakcrest is looking at a non-degradable delivery channel to the extreme left. It needs removal. There are some, many others. I've just talked about the Conrad subdermal pellet, and there are many, many other next generation implantable drug delivery systems. And there are other novel drug delivery systems in preclinical development pipeline. To the extreme left, I want you to pay particular attention. This is a multi-purpose intrauterine device system, which it releases antiretroviral as well as for pregnancy prevention. So this field is really exciting. We have many, many products. I like the box office, and recently I watched The Matrix, and Neo from Matrix said, I don't like the idea that I am not in control of my life. So we need to be in control of our lives, and The Matrix The study, USAID funded matrix, has really come up with products that women can use to prevent HIV. There are many products that are in the pipeline, but most of them are still in the early stages and have not been rolled out into clinical trials yet. So this is the pipeline, or the product pipeline for Matrix, and I think Shannon, she is here, I hope she's here, she's going to talk about this. We've already got 3 products which are at an advanced stage, which will look at vaginal films, which will look at fast dissolving inserts for HIV prevention in women in the US, Kenya, South Africa, and Zimbabwe. So we'll hear more about the matrix from Shannon later on. So in summary, this is an exciting field. We need a diversity of prevention options and programs to address diverse needs of people at risk for HIV. And as I've just shown, the HIV prevention field is evolving faster than ever. And the bar for developing better, more efficacious, safer products it continues to rise. After all has been said and done, we need to come up with a new prevention technologies that are acceptable, affordable, scalable, and deliverable. With all that, I'm hoping that we will significantly have the potential to end HIV using these biomedical interventions. Thank you so much. Obrigada. Thank you.